Medical Director, Fertility Associate Center of ART Mumbai. He was formerly Medical Director, Regenesis Reliance Life Science ART Mumbai, and he is Associate Professor, Somaya Medical College, Mumbai. He has to his credit many up to 35 scientific publications and several book chapters, and he has been invited as a guest lecturer to across India and abroad, and he has won many national and international awards. He has 2 international patents to his credit for work in infertility and embryonic stem cell research, and he is the past president Mumbai OBGY Society 2014-15, chairperson West Zone RCOG 2015-19, and currently he is the vice president ISAR. With this, I welcome Dr. Amit Patki. Over to you, sir.
A very good evening to all listeners. It's a great pleasure and honor to moderate a session where 2 of my very good friends will speak to us on unraveling mysteries in PCOS. As you will all agree with me that polycystic ovary is like a pandemic. The incidence has remarkably increased over the last 10 to 15 years. And we all know that it is because of various reasons, but the most important pillar is lifestyle disorders. This is one of the first of the series on PCOS, and we will now listen to Dr. Manish Banka. Dr. Manish Banka, to formally introduce him, is the medical director of Nova IVF Fertility, is the past president of ISAR, is a recipient of the Dr. B.C. Roy Award 2018, is a board member at various different prestigious boards, notable to mention the Poseidon Group and the Aspire organizations. Manish will discuss with us about diagnosis of PCOS in the 2 extreme age groups in adolescence and perimenopause, and also put forward the differential diagnosis. So over to you, Manish.
Thank you very much. It is indeed a pleasure to be on this panel, a series of talks on polycystic ovarian syndrome. And as Amit had mentioned, I will start the ball rolling by talking about the issues of PCOS at the 2 extremes of a woman's life. If we look at the clinical presentations of polycystic ovarian syndrome, we have various features here, and this is the time span in a woman's life. And you can see that different features are manifested at different ages in the woman's life. Things like obesity start from early childhood and persist right till the end, whereas things like infertility would only evolve during the reproductive years. So not only is the disease having multiple symptoms, even the manifestations of this disease are different at different ages in a woman's life. Keeping this in mind, let me take you through the 2 extremes. I will not take you through the diagnosis, the Rotterdam consensus, because this is all known, but let me focus on what are the challenges at these 2 extremes of a woman's life. Amongst adolescent girls, PCOS is the most prevalent endocrinopathy. It is present in nearly 10% of adolescent girls. This prevalence is also rising predominantly because of a relatively obesogenic environment, because obesity is the next big killer in the Western world and moving also to the Asian countries. This adolescent PCOS is also driven by an ensemble includes central obesity, insulin resistance, LH hypersecretion, and low concentrations of adiponectin, which is the key adipocyte for insulin sensitizing properties. It is also important to remember that this is a crucial time to diagnose PCOS, because this is the time frame when these young girls will start gaining weight. And this is the earliest that we can give them a warning that you have a possibility of this later complications, and a course correction at this early stage in their life will go a long way in preventing or at least minimizing some of these consequences. For the adolescent PCOS, there are certain changes in terms of the standard features and the updated features. And let me just give you two examples to begin with. We always thought that it is the PCOS which causes obesity, but the update here is that for this young adolescent girls, or this is probably the beginning where it is the obesity pushes them towards the development of PCOS, or what was initially thought as a monogenic disorder, we now know that there are a large number of susceptible loci across various genes which are possibly responsible for this. So there is a changing paradigm on what we were thinking earlier to what is the current available evidence. With this, let us see what are the problems here. Now, there are quite a few diagnostic challenges in these young girls. One, because it is commonly present during adolescence, it is important that we diagnose this condition as early as possible to, as I say, prevent the future metabolic and cardiovascular risks. Second, a large number of cardinal features of PCOS, like acne, menstrual irregularities, these are common issues in normal puberty, and it is very difficult to distinguish normal physiology from a pathology. And because of this, there is a possibility of both overdiagnosing or underdiagnosing this syndrome. People have reported that the major challenge is underdiagnosis rather than overdiagnosis, and this delayed diagnosis leads to a limited opportunity for educating them and to help in preventing and treating these symptoms. So this young woman should also be commenced on a combined OCP if you have a doubt, even prior to assessment and diagnosis, potentially to delay the diagnosis. Now let us look at individual features. Menstrual irregularity, which is so important in the women of reproductive age, this has been subjected to the greatest controversy when we look at adolescent, because we are whole talking about this pubertal transition. Irregular cycles and ovulatory dysfunctions are a normal component of pubertal and menopausal transitions. This is because the hypothalamo-pituitary axis is still not mature enough, and it takes years for the axis to mature to reach the reproductive potential. So when these irregular cycles reflect reproductive maturity, or when it is diagnosis or indicative of PCOS, this is the big dilemma. So, what one should look for is that for these girls, we should have a new definition for irregular menstrual cycles. And this is what it should be, that beyond in the first year post menarche, this should be purely considered as pubertal transition. After 1 year of menarche and up to 3 years post menarche, cycles only if there are less than 21 days or beyond 45 days, only then they should be considered abnormal. Cycles between 21 to 45 days, between 1 to 3 years of menarche should be considered as normal. Once she moves beyond 3 years of menarche, then cycles between 21 to 35 days should be considered normal. Or if the woman has less than 8 cycles in a year, only then it should be considered abnormal. Or post menarche, if she has even one episode of 3 months of amenorrhea, then that should be considered to be significant. So if we use these guidelines, it will go a long way in differentiating a physiological menstrual irregularity from the polycystic ovarian syndrome. So based on this, the ASHRAE uh, and the PCOS Society, they came out with guidelines on the diagnosis and assessment of PCOS. And what they mentioned in the guidelines was that in an adolescent with irregular menstrual cycle, the value and optimal timing of assessment and diagnosis of PCOS should be discussed with the patient, because we need to discuss that there are challenges in this. And in patients in whom there is a doubt, but we cannot have all the diagnostic criteria, these women should be classified as an increased risk, and they should be evaluated again somewhere 8 years post menarche when they reach their full reproductive maturity. So, from a normal woman, or between a normal woman and a woman with PCOS, we could have a subcategory of those at risk who should have a second eventual evaluation 8 years post-menarche. The second issue is that of ultrasound. Now, this is one of the cardinal diagnostic features in women in the reproductive age. But for young adolescent girls, this is itself is also a challenge. This is because, first, the ovaries reach its maximum volume only somewhere between 1 to 4 years after menarche. So, the whole concept of volume gets a toss because the ovaries may not have even reached their normal potential. Second, in adolescent girls, large multicystic ovaries are common. Third, ultrasound alone is not predictive for the presence or future development of PCOS, and it should not be used as a first line diagnostic tool in women with PCOS. Secondly, there is also heterogeneity in ovarian morphology, the issue of the stromal density, etc., because the criterias have been, or whatever normative data that we have is based on adult women. We simply do not have sufficient data from adolescent girls. So this ultrasound criteria is an issue, and the ACOG guidelines suggest that pelvic ultrasonography should not be routinely used unless you have some elevated serum androgen levels or you have a concern because of excessive degree of virilization. So the use of pelvic ultrasound actually may increase the risk of overdiagnosis of PCOS in young adolescent girls. So what the guidelines suggest is that ultrasound should not be used for diagnosis of PCOS in women under the age of under the reproductive age of 8 years. That means it is before 8 years after menarche due to the high incidence of multifollicular ovaries. And hence, in women who have irregular menstrual cycles or young adolescent girls who have irregular cycles and hyperandrogenism, an ovarian ultrasound is not necessary because it will only help in identifying the phenotype. It does not alter your diagnosis. We then move on to the third cardinal feature, and that is of hyperandrogenism. Again, PCO is one of the most common cause of persistent hyperandrogenism beyond puberty, and it is thought to affect between 6 to 15% of women in the reproductive age. But again, here also, there is a great overlap between symptoms of PCOS and those of normal puberty. What about biochemical versus clinical hyperandrogenism? What to measure, when to measure, how to measure. This is even more challenging in these young adolescent girls. So, what has been suggested is that if you want to calculate, and these guidelines are more towards women in the reproductive age, you should use free testosterone, free androgen index, or calculate the bioavailable testosterone for diagnosing PCOS. But this is not very accurate in women who are on hormonal contraception, or if the young adolescent girl has already been put on an oral contraceptive pill. In that case, we should wait for 3 months beyond the stoppage of the pills before you measure this. But clinical hyperandrogenism is also a challenge because the clinical definitions of excessive hair growth are based upon the standards and definitions which are derived from adults. We do not have these guidelines for adolescent girls because for this diagnostic for these young adolescent girls, hirsutism may not be fully realized in the adolescent girls, and it might actually develop fairly later on. So in the young adolescent girls, and the diagnostic criteria in terms of hyperandrogenism is severe acne or severe hirsutism. Mild to moderate acne or hirsutism should not be used as a sign of diagnosis. Again, alopecia or other features are extremely uncommon in these young adolescent girls. Then what about moving on to AMH? Because this is gaining increasing popularity because it is a non-invasive test, just requires a blood test. And you don't need an ultrasound looking at the PCOS morphology, but we still do not have standardized criteria on the cutoff values on AMH. So the evidence-based recommendation is that it should not yet be used as an alternative to detect polycystic ovarian syndrome. Maybe with time, when we have more normograms, this might become easier. Hence, There is a thought that adolescent PCOS should now be defined by the co-presence of irregular menstruation and androgen excess beyond 2 years of menarche and by exclusion of other androgen secreting tumors. Ovarian morphology should not be used as a diagnostic criteria. Irregular periods, androgen excess beyond 2 years of menarche in the absence of other androgen secreting disorders should be sufficient. And for young girls who are at doubt, we should have this criteria of at risk of PCOS, and these women should be evaluated on a regular basis, the final evaluation happening 8 years post menarche, so that we can finally label them either as normal women or as women who have actually moved into PCOS. So this timing, it should begin at 3 years post menarche, and the final diagnosis should be 8 years post menarche. And this is particularly important for adolescent girls because we need to use this for their subsequent management as well. The differential diagnosis hence falls primarily of hyperandrogenism, and this should be with things like physiological hyperandrogenism of puberty, idiopathic hyperandrogenism, non-classical congenital adrenal hyperplasia, other androgen secreting tumors, hypothyroidism, Cushing's disease, or severe hyperprolactinemia. So what does the ACOG recommend in this? This recommendation is that you first go with the history, menstrual history, and we need to use the criteria to define oligomenorrhea. We then do a physical examination looking at the severity of hirsutism and acne, and based on whether the periods are regular or irregular, you order the laboratory tests if required, and this, by excluding other pathologies, will help you in arriving at the diagnosis of polycystic ovarian syndrome. A very few slides on the management, because I'm sure this will be taken in detail later on. But important to remember that to inculcate the belief or the features of healthy lifestyle is paramount importance, because this is the earliest opportunity that you get to condition these young women, and we should set in achievable goals of between 5 to 10% weight loss if they are obese. The other common issue that comes in is, should we use the combined oral contraceptive pills alone, or should we use them in combination with others? And the recommendation here is that lifestyle modification and the combined oral contraceptive pills should be considered as the first line of treatment. The other types of progestins, estrogens, or combinations cannot be recommended for adolescent girls till we have sufficient evidence. I now move on to the other extreme of the woman's life, and that is in the perimenopausal age group. Here again, the challenges are more or less similar, because the manifestations or defining the manifestations of PCOS in older women is complicated, because certain features of the typical menopausal transition overlap with the findings of PCOS. There is also sometimes inadequate evidence, or we still don't have pure complete evidence on the natural history of PCOS. That is, if a woman has PCOS in a reproductive age group, does PCOS resolve and simply disappear once she enters menopause, or does it persist post menopause? This we still do not have large longitudinal studies on this aspect. Keeping this in mind, again, there have been certain shifts in the paradigm for the diagnosis of PCOS as well, and I will take you through these changes again. So with ages, changes occur in all the three diagnostic criteria of PCOS. Menstrual cycles start becoming regular in women with PCOS. Ovarian volume and the follicular number starts to decrease, and the androgens also start to decline with age in women in general and also in women with PCOS. Secondly, we still don't know what is the effect of PCOS on the age at menopause. It is believed that there is a 2-year delay in the age of menopause based on estimates based on AMH levels, but we still do not have this conclusive evidence. So let us look at what happens to the features. And again, we begin with menstrual irregularity. Now, as a woman approaches perimenopause, women with a history of regular menses typically experience oligomenorrhea, menomenorrhagia, or metrorrhagia. That is, a woman who does not have PCOS but has a regular cycle starts to have irregular cycles. Conversely, in a woman with polycystic ovarian syndrome, cycles tend to become more regular as they approach menopause. So there is a contradiction here. Hyperandrogenism, hirsutism is greater in women with PCOS than in controls, even in the postmenopausal women. But we still know what happens to acne and alopecia, two major features of the polycystic ovarian syndrome in the younger women. Sex hormonal concentrations also change. So, postmenopausal women with PCOS have higher levels of 7-hydroxyprogesterone, androstenedione, DHEAS, testosterone, and free androgen index. But again, androgen levels are not very reliable because overall the levels are lower one post menopause. Polycystic ovaries on ultrasound also is a problem because the ovarian volume starts to decrease in all women, including those with PCOS. However, when we compare this with age-matched controls, the ovaries with PCOS do not meet the diagnostic criteria or the morphological criteria of PCOS. So, women with a history of PCOS who had polycystic ovaries earlier also fail to exhibit this typical ovarian phenotype post menopause. So, all the three cardinal features of the polycystic ovarian syndrome start to fade away once the woman enters the perimenopausal age and reaches menopause. The question then is, has PCOS as a syndrome disappeared? This is the biggest challenge. So what is recommended is that postmenopausal persistence of PCOS should be considered most importantly on the continuing evidence of hyperandrogenism, or the diagnosis should be considered if we have a past history of diagnosis of PCOS with a long-term history of irregular menstrual cycles and hyperandrogenism during the reproductive years. So we are just assuming that if she had a long-term history with confirmed diagnosis of PCOS, the syndrome persists. The challenge is that if you have a postmenopausal woman who presents with new onset symptoms or worsening of hyperandrogenism, this is the time when we should try to look for other androgen secreting tumors, and we should not consider this as a worsening of the polycystic ovarian syndrome. The differential diagnosis, hence, again, is more related to hyperandrogenism or tumorous hyperandrogenism, because this is what we are worried of and we should look for. The one condition which we are always worried of in this elder women is the occurrence of the metabolic syndrome. We know that compared to young control women, young women with PCOS have increased obesity and an increased waist to hip ratio. The change here is also very palpable, that with menopausal transition, the incidence of waist to hip ratio becomes less in PCOS as opposed to control, so that there is no significant difference in the normal and the PCO woman post menopause. The second major question here is the occurrence of endometrial cancer. Are women with PCOS at an increased risk of endometrial cancer, and what should we do for this? So the guidelines recommend that association between PCOS and endometrial cancers are complex with many potential confounders, and routine screening for endometrial cancer with a biopsy is not recommended. However, vigilance and awareness of the risk is important. So women should be counseled that there is a 2 to 6-fold increased risk of endometrial cancer. They should also be told that investigations like a transvaginal ultrasound looking at the endometrial thickness is very much important. And if a woman has cycles longer than 90 days, they should be put on some kind of hormonal treatment. So to summarize, the challenges here are there is lack of normative data for women at this extreme stage. There are dilemmas in diagnosis because we need to differentiate between what is physiology and what is pathology. We need to keep an open eye on differential diagnosis, especially for androgen secreting tumors. And in women at these extremes, PCOS is more a diagnosis of exclusion. And whatever is the condition, frequent monitoring and long term surveillance is very, very strongly recommended. Thank you very much.
Thank you, Dr. Manish, for an excellent overview on both the extremes in life on adolescence and perimenopause. As we introduce the topic, we know that adolescent PCOS is on the rise. It's a dichotomy in our country where one hand we have severe malnutrition in children, but we also are seeing large number of childhood obesities in our country. So we are grappling with both the problems. And I think it is important in adolescents to counsel them, to educate them, to empower them to look after themselves so that they do not land up with problems during the fertility and latter stages of life. You have also very beautifully told our viewers about how to look after women, because most women after their childbearing age do not give much heed and significance to their menstrual irregularities. And often we miss the boat to counsel them and prevent the metabolic X syndrome that we often see in the perimenopausal age. So I'm glad you have highlighted these points. Before we move on to the next speaker, I would like to request all our viewers to put in their questions, their queries into the chat box or the question answer box, which is at the bottom of their screen. I now invite our next speaker, Dr. Sujata Kar from Bhubaneswar, who's actually the one who has brought this whole thing together and started this program for us. She is the honorary treasurer of ISAR, winner of 7 gold medals in her MBBS and MD academic years, and is credited with the first IVF baby of Eastern Orissa. Amongst the several awards that she has received, most notable is the Parichay Award for Women Achiever, which she received at the hands of the honorary governor of Orissa. Dr. Kar will speak to us on the pitfalls in the diagnostic criteria for PCOS. Dr. Sujata Kar.
Good evening, everybody. Thank you, Amit, for your introduction. So I am to speak on the women in the reproductive age group and the updated criteria for the diagnosis of PCOS. Now, before we brand anyone as polycystic ovarian disease with likely long-term comorbidities and impaction, it is mandatory that we make a correct diagnosis, which is the key for managing these kind of patients. And over the years, the international consensus for diagnosis and definition of PCOS started with NIH and then Rotterdam criteria, and now in 2018 the international evidence-based newest criteria, that guidelines that we have. In between, the consensus meets were mostly for management of PCOS. Now, I'll just take you through a little bit about history so that it's little interesting. The NIH was about hyperandrogenemia and chronic anovulation. Rotterdam added polycystic ovarian morphology. We know the criteria, so I'm not going to go into details. The point is that Rotterdam did not include the importance of thick stroma or the distribution of follicles in the ovary. Neither did it, put the importance of age, ethnicity, race, the fact that oral contraceptive use might change polycystic morphology, the lab testing. No hormonal test was, a diagnostic test. So it was just a clinical diagnosis, and polycystic ovarian morphology was an important part of it. The Rotterdam criteria gave rise to 2 new phenotypes. The first and the A and the B are known with the NIH criteria also, the full PCO and the one in which there is no PCOM but only hyperandrogenemia and anovulation. These two were old. The new criteria was C and D, the new phenotypes. C was the one in which there was no anovulation. The women were normal cycling women. And the fourth was the one in which there was no hyperandrogenism. Now, the PCO phenotype 4 is a large, sizable, chunk of the PCO women that we see. That is, women with polycystic morphology and anovulation, but no hyperandrogenism. That is a sizable chunk. That added quite a few numbers to the diagnosis of PCOS. The small bit here, which is the PCO phenotype 3, which is there is no irregular cycles. There is PCO morphology and androgen excess, but the woman is normal cycling women. So this is a very small chunk, I would say, because the paper that I published in 2013 about phenotypes in our Eastern Indian population, this group, this phenotype was hardly 1 or 2%. But literature shows a very varied prevalence. Up to 20% also has been reported in some of the papers. But this phenotype is really hard to understand because they have regular cycles and we are hardly likely to see these women. Probably the scan people will diagnose them, and probably the skin, dermats or the endocrinologists might see them, but we don't see them so often. Now, we also know, and we must remember, that there are many young, normally cycling, normally fertile women who have polycystic ovarian morphology and ultrasound. This is a known fact. Now, between normal ovary, normal morphology and function, and polycystic ovarian morphology and hyperandrogenism, which is at the two ends of the spectrum, there are many normal variants. And this is the part which we do not understand. And it is possible that a lot of wrong diagnosis or overdiagnosis or underdiagnosis, missing out on PCO women who actually need care, might result because of this fact. Now, since 10 years and 15 years had passed, and there was a lot of controversy and less consensus and more controversy on the Rotterdam criteria, in 2016, Dider-Diwali published, "Is there a need to rethink about the criteria for diagnosis?" He said that these classifications are now more than 10 years old. So although fundamentally it's still valid, the 3 parameters, the 3 criteria, but each of them needs to be updated because there is so much information that we do not know, and a new consensus is really required. And today we have that consensus. In my lecture today, I'll just have 2 parts. One is, can AMH become a new diagnostic marker? I'll show you some evidence, and critically evaluate each of these 3 Rotterdam criteria in the reproductive age group. Manish has very nicely evaluated each of these criteria for the adolescent and the perimenopausal. Now, the new international criteria that we have is really a document to reckon with, because it covered 6 continents and it covered all the possible specialities. 71 countries and some 37 societies were involved, and they sat for 15 months. So it was not like a small little document like Rotterdam criteria, So, and they asked 60 clinical questions and came out with 166 recommendations. So it was a really good, and today we are going to base our lectures on these recommendations. So AMH and polycystic ovarian syndrome, or PCOM morphology, have been thought to correlate since a long time, because it has been shown that serum levels of AMH are at least 2 to 3 folds higher in PCOS women and 5 folds higher in their follicular fluids. And also the antral follicle numbers are more, and they are consistent with the serum AMH level quite often. And it is also possible that each follicle secretes more AMH than a normal ovarian follicle. So it is likely that AMH and PCO pathophysiology are closely interlinked, because AMH levels and PCOM levels have also been correlated with clinical manifestations, the severity of PCOS manifestations. So AMH is not only a biomarker, but it is also involved in its pathophysiology. And it would seem as though in PCOS women, a normal functional and highly sensitive follicles capable of ovulation are just frozen in time. And it appears that AMH is a key factor. Though AMH is a key factor, the major limitations now are that we do not have cutoffs for populations and we do not have standardized assays. So although this is a promising biomarker, the assays are really disappointing. They are not unfortunate. Accuracy, reliability, reproducibility, and standardization is very poor, and variability is really large. There are a lot of assays that are coming in. The latest one, PICO assay, promises that it has a very, very high sensitivity, but we are still not there. Other than that, the fact is that there are a lot of racial and ethnic differences that have been reported in cutoff levels for PCOS and AMH. Korean study reported a AMH cutoff of 10 nanogram. Taiwan, 4.7 nanogram. China, 8 for age group 20 to 29 and 5.8 for age 30 to 39. And Indian population, Nalini Mahajan and group reported a cutoff of 5.3 nanograms. So we cannot have a single cutoff saying that this is the AMH above which we can diagnose, PCOS. So even the recent guidelines tell us that although this is a very promising marker yet, but we are still not there. We still need more research and more time before we are able to decide. Now let's look at the 3 parameters in the reproductive age group. The Rotterdam criteria, which is still followed massively or worldwide, makes ultrasound as a very important criteria for diagnosis of PCOS because it's part of one of the criteria. And we rarely get good reports. The reports are actually, even a 2D report is supposed to inform us of so many parameters, which rarely we get a report similar. And moreover, since 2003, then when the Rotterdam criteria was set, there has been so much advances in technology in the ultrasound technology. And today we have fantastic ultrasounds and beautiful softwares within a click give us data like this, and you can have a 3D count, etc. It's like really good, and the capability of the ultrasound machine to pick up really small follicles has tremendously improved. So based on that, the Androgen Access Society set up a task force to decide on the criteria for polycystic ovarian morphology for the diagnosis of PCOS. And they recommended that PCOM should be more than equal to 25 follicles per ovary. And of course, the specifications for the type of transducer, at least 8 megahertz or more, and the type of ultrasound machine that you should use, etc. were given. Ovarian volume, of course, remained at 10. Around the same time, a lot of Asian data started coming up. The PCOS androgen access recommendation that I showed you here showed mostly Caucasian women, and they had a patient population of about 400 women for this particular document. Meanwhile, a lot of Asian data started coming up, which showed us a much lower thresholds for cutoff for PCOS diagnosis, ranging from 8 to 12 or 15 at the most. And those patient data is a large data set of about 1,000 patients. Even I published in 2014 2D, 3D for our population here, and showed a much lower cutoff of 10 using 3D and 12 using 2D. PCOM I'm talking about. PCO, I mean the FNPO, the follicle number per ovary. So it appears that the race and ethnicity is also very different to decide what should be the cutoff for polycystic ovarian morphology. Now, another problem with ultrasound and polycystic ovarian morphology is that the fact that AMH is also a player in deciding what kind of a follicle numbers she has in her ovaries. And so their papers started coming out that maybe it's better if we use both AMH and PCOM to decide on the criteria for cutoff. And that would also be an excellent possibility if we have more studies out there, and it would totally eliminate the phenotype B, in which there is no polycystic ovary, if you remember the phenotype B of the Rotterdam. So using both would be absolutely great. And the third point with using ovarian morphology for a cutoff, the problem is the age factor. Manisha has also told us that in adolescent, we cannot use ultrasound as a diagnostic marker. And even in perimenopause, it becomes different. So age is a criteria. At younger age, you have larger number of follicles in the ovary. At a higher age, you have a greater number. So that's another problem why how to define polycystic ovarian morphology becomes a real problem. So to summarize, the Rotterdam criteria is certainly obsolete because it does not, and the fact that there are a lot of variations in race is now already published and shown. And there are so many variables: age, race, ethnicity, scan probe frequency, the sonographer who is doing it, what phase of her menstrual cycle she is in, what machine you're using, and whether she's been using medications like oral contraceptive pill, etc., etc. So it's really a problem. So the current guidelines, the international guidelines, what do they tell us? To tell you in a very simplistic manner, I think it has just undermined the role of ultrasound in the diagnosis of PCOS, whether it is in adolescents or it is in regular reproductive age adults, or it is in the perimenopause. Ultrasound loses its importance with these new guidelines. But then if at all we have to follow them, there are very much specifications, which I hope not only we as reproductive medicine specialists, but also the sonologists who give us the reports would educate themselves and come up with proper reports for polycystic ovarian morphology. Now, the second point was anovulation. I think that's pretty straightforward, except for few points. In the reproductive age group, we should have less than 21 days. I'm sorry, reproductive age group, we should have less than 21 or more than 35, or at least 8 cycles a year. But we should not forget that ovulatory dysfunction can still occur even with a reasonably regular cycle. So there comes the role of serum progesterone, but let me not go there because then that will raise more questions than answers. Just remember that a woman with irregular cycles or a reasonably regular cycle can still be anovulatory. Hyperandrogenism clinical is the first thing that we have to look for in our patients, not the biochemical. That comes next. So clinical hyperandrogenism, we are supposed to rely on a scoring system like a Ferriman-Galway score. FG score modified of more than 4 to 6 indicates hirsutism. But here also a couple of reminders. The fact that epilation amongst girls, young girls and women is very, very common. And this can limit assessments. So you cannot easily do it in the outpatient. You need to call them back if they have removed hair from their face or body, and then reassess. And the second point is we should not confuse villus hair with the terminal hair, the adult hair, because that might lead to a lot of confounding. The second point is the female pattern baldness for this Ludwig's visual scoring system is. This is a very good indicator of hyperandrogenemia, and it should be regularly used. Acne is not a good parameter, because we know that a large number of women have physiological acne, and there are many other variables also. So what I generally prefer is you can ask whether they have acne in the back and upper arm. Now that would be a good indicator of clinical hyperandrogenemia, rather than the facial acne, which has too many things. If you do not find clinical hyperandrogenemia, only then you should go look for biochemical hyperandrogenemia. But that issue is going to raise more problems for you for diagnosis than it's going to solve. Couple of questions: which androgen should you test? Which assays should you use? And more important is whether we have a cutoff values of serum androgen in Indian population according to their reproductive age. So that is another major limiting factor as to how we should test for clinical or biochemical hyperandrogenemia. And many more problems with serum testosterone testing, whether total testosterone, free testosterone or free androgen index, is the fact that there is a pulsatile release during the day, and there is a lot of diurnal variation, higher in the morning, lower in the evening. And there is a menstrual cycle variation. There is a mid-cycle peak of testosterone. Free testosterone, I believe, is higher in summer than in winter. I never knew this. And levels decline with age. In the perimenopause, Manisha has shown us that androgen levels are lower. So interpretations are very difficult. Which test to use is even more difficult. I think I have that. Yes. So the best, according to the recommendations, are use free testosterone. Free androgen index is probably the best as clinical, as evidence-based medicine. But this is as to what has been published. But where clinical practice point, from clinical practice point, a total testosterone could also be all right because it is cheaper. A total testosterone will cost you around 250 or 300 or 500 rupees, whereas a free testosterone will be much higher. Free androgen index will also involve calculating SHBG, so that will be much more clear. But if you have some kind of a cutoff for your population that you've been seeing over the age to define hyperandrogenemia, then a total androgen testosterone level also is a good point. But the most important thing is the assay method should be correct, and you should be using the correct and methods of like Manish has mentioned in his slides. So anovulation and hyperandrogenism, also you have to be very careful as to how you define them. You have to relate them to age. You have to consider ethnic variations. You have to consider familial variations. Whenever you're looking at hyperandrogenemia, always look at the sister, at the mother, and that might help you in clinching whether she has. And of course, we do not have a a racial or our population-based cutoff like many populations have. I have shown you here, this is for Iranian population, this is for Chinese population. They have cutoff levels for their population as to this is what will define hyperandrogenism in our population. So my final slide, diagnosis of PCOS, very simplified, rather ultra simplified. This is a clinical diagnosis. You barely need any tests to diagnose it. So any woman who comes with irregular cycles, look for clinical hyperandrogenemia. If she has clinical hyperandrogenism and you have been able to exclude other causes, you have the diagnosis. If there is no clinical hyperandrogenemia, then test for biochemical hyperandrogenemia. When you test for biochemical hyperandrogenemia, exclude other causes. Like if it's ultra high, then you know that it's any of the tumors or adrenal or anything that you have. And then if you have biochemical hyperandrogenemia, then you have the diagnosis. You have irregular cycle, you do not have clinical hyperandrogenemia, you test biochemical, you have that, you have the diagnosis. Only if you have only irregular cycles and no form of hyperandrogenemia, or you have only hyperandrogenemia, clinical or biochemical, and you do not have irregular cycles, then only do you consider an ultrasound. This is the latest international guidelines. Like I told you, it really undermines the importance of ultrasound in the diagnosis of PCOS. Thank you very much.
Thank you, Dr. Sujata, for such a lucid presentation, because I often tell my colleagues that PCOS is the most difficult woman to treat, particularly in infertility. But you have made it very, very simple. I would again request all viewers to put in your questions, and large number of questions have come in. So we will start with the question answer session. And the first and the foremost question that has come up, Dr. Sujata, is that do you use to diagnose insulin resistance? Do we use the HOMA IR test? Is that the norm, or we can use something else?
No, HOMA IR is quite cumbersome. It is not a norm at all. If you want to test insulin resistance, then a regular glucose tolerance test should be enough.
Okay. Now, I also want to add that is it necessary to measure insulin levels to diagnose PCOS, to diagnose hyperinsulinemia?
There is no role of diagnosing high insulin levels in PCOS at all, because it's not going to change our management or diagnosis.
Absolutely, because this is something that I think this should be the first take-home message for viewers, that although we say hyperinsulinemia, but we don't want to necessarily measure, because as Dr. Sujata rightly said, and also it is very difficult to get those assays done and rather expensive. So we would not like to do those assays. The second question is that in a young PCO who's unmarried with normal body weight and with secondary amenorrhea, what would be the ideal treatment for such a woman? Ideal management. So she's got secondary amenorrhea, she's single, and she has got normal BMI.
I suppose that they have looked for clinical hyperandrogenism, and if necessary, tested for total testosterone or free testosterone or whatever, and also excluded the appearance or whether she has hirsutism and acne, whether those are the things that are plaguing her, whether she has acanthosis. Even with normal BMI, they can have all this.
Yes.
I think if those are present, it will help a lot in deciding how to manage her.
Absolutely. But if all that is absence and she just wants to get regular menses, I think the drug of choice should be the oral contraceptive
Yes.
pill, and that is the drug of first choice to regularize periods. I don't think we need to also use any anti-androgenic pills. We can use the routine pills, and only in cases where these routine pills do not take off the symptoms of hyperandrogenemia for 3 to 6 months, maybe we could add uh, these other
Absolutely,
right?
absolutely. And even the oral contraceptive pill, the constituents are also not very important.
Yes.
One doesn't have to use the expensive
Third generation, yeah.
fourth generation.
And you could even use the low dose pills because that will also work effectively.
Absolutely, absolutely.
Now there's a question saying that quite often in PCO patients, although you get good numbers of oocytes in IVF, we often find that the quality is not as good enough. So what could be the reason for the egg quality being poor?
Now that is a difficult question because a lot depends on what stimulation protocol and what triggering has been used for that particular PCOS women. And also the fact that we know that inherently most of the oocytes are not good. I mean, they are not euploid. They are not, they are not
Genetically normal.
they are, yes, exactly.
Yes.
So PCOS women per se do not have poorer quality oocytes compared to other women. That is what I would say.
And more important is their workup. If you just push somebody into IVF without actually having them to lose weight or get their sugars under control, I think that could be one of the reasons for getting poor oocyte quality rather than the PCO per se, as we would say.
Absolutely.
The other question is, in what is the drug of choice? Is it myo D-chiro combination or metformin?
For which patient? That would be the question.
Now, they have said for adolescent patients.
For adolescent girls, if they are obese or overweight, showing features and with a strong family history of diabetes and features of acanthosis, etc., definitely metformin would be my choice. I am not so much. I don't have experience with myoinositol too much. I wasn't a believer, let's say, till now. I use metformin. So I cannot really say. Even the evidence seems to support metformin. There's more papers out there for metformin. It's been used longer. So it's difficult for me to say whether myoinositol is going to act as well as my metformin. I don't think so.
I agree with you because we have all practiced with metformin, and the latest classification also says that metformin, and they don't make much mention about myoinositol. But in the last 2 years, there have been quite a large amount of extensive work on myoinositols and combination of myo with D-chiro and combination of myo with metformin. So we have these various different combinations. And personally, in my opinion, if it's an adolescent girl with irregular periods, myoinositol alone can work well. In the severe PCO, which doesn't respond to metformin, I think metformin-mayo combination works particularly well in the perimenopausal age, where there is even weight gain or increased BMI is seen in these women. How long can you continue with the contraceptive pill is one question.
Again, in adolescent age group, I presume.
Yes.
So theoretically, you can continue for a long time if the girl does not have any metabolic abnormalities like abnormal lipids or abnormal glucose challenge test, or she doesn't have a history of liver disease, etc. The regular contraindications.
Yeah,
because for the purpose of contraception, there are papers which show it has been prescribed, it has been taken for 15 years, 10 years, 15 years, like that. However, for PCOS, we don't have too many papers. But going by those reports, it will be fair if they can be prescribed for a pretty long time.
Yeah, I think it is important because a very good take home message is that quite often, maybe 10-15 years back, some of the gynecologists used to prescribe the clomiphene citrate to these patients just to get them regular periods. I think that practice should be completely avoided. It should be the drug of choice, should be the COCs, because
Yes.
that way you are actually even conserving the ovaries in such patients, particularly if there is some associated endometriosis or something. Then it works very well for both the conditions, will keep the endometriosis in check and will also ensure that she gets regular periods.
Also, one little practical point: whenever you're putting a girl on COCs, then it's a good point to ask her to come back regularly, at least a yearly evaluation. And during that time, I ask them to go through the lifestyle changes, the 3 things that we advise them. And if they have been able to get into some kind of a weight control, regular exercise, and proper dietary pattern, and they have lost, let's say, 5-7 kgs, then it may be okay for you to stop the COCs for some time and see what kind of a cycle she has. There are many girls who go back to 8-10 cycles per year, and they're happy with that, and you are happy with it. So that's a good point.
Yeah, I think that is another good take home message Dr. Carr has given, that it is not really necessary that every woman should get periods every 28 days. As long as they have intermittent shedding of the endometrium and they get at least 8 periods in a year, I think that should be good enough. There is one question which has said that, can you explain the role of DHEA in PCOS? Or is there any role of giving DHEA in PCOS patients?
No, there's no role at all, I think. I mean, how is it
I
related?
think this question has been asked because there have been some people who have advocating, in fact, giving DHEA to improve the egg quality in PCO patients. But frankly, PCO patients would have hyperandrogenemia, and you would be in
Yes.
fact making the condition worse, if not better.
Yes, exactly, because it's just the opposite of what you're doing and what is required. So there is no role of DHEA at all in PCOS, I would say.
Yeah, I agree with you. I'm just scrolling down the list, and okay, there
Insulin
are
resistance to add to metformin.
yes, there is a
So
question.
whether you should measure insulin resistance, you should definitely measure glucose, a fasting blood sugar, and a GTT before you prescribe metformin. I would do that for all girls before prescribing metformin, but not insulin resistance per se.
And do you continue metformin in the first trimester if somebody has conceived on metformin and
I
COS?
continue for the first trimester, and I continue throughout if they are obese, they have a family history, or if they continue to have HbA1c and sugar levels, which entails us to continue it.
Yeah, or if they've had impaired glucose levels pre-pregnancy, it would be worth continuing, because that way you will reduce their incidence of getting gestational diabetes in pregnancy. And now it is considered quite safe to continue. And in fact, we have seen that even if you continue for the first trimester, your live birth rates are much better in
Yes.
patients who have taken metformin in the first trimester.
Perinatal morbidity also, the macrosomia, all the complications are less.
Yeah. So I know that PCOS is a never-ending topic. I think there is lots more to discuss, but this is one of the first of the series that Dr. Sujata Kar has put together for all of us. And I think on behalf of all the viewers, I would like to thank Dr. Kar, thank Intas for having organized this wonderful webinar. Dr. Sujata.
Thank you, Amit, for joining in and giving your valuable, experience and expertise. And thank you, Intas, for having letting us do this. And I hope that we will have some kind of a regular a program for unraveling PCOS and have clinical case discussion on diagnosis next time.
Excellent. So can we have Mr. Satpathy have the last word before we close the webinar?
Thank you so much for giving us this opportunity to do this webinar. And as Madam said, we'll be really interested to do a series of webinars on this. And probably we'll start promoting this as a series starting from tomorrow. So we can schedule the dates, and next time when we do the program, we can announce the next webinar.
That will be nice. Thank you so much. Thank you.
Thank you very much and take care.